In this episode of the Brawn Body Podcast, I'm joined by my friend Dr. Jonathan Harned. John earned his Bachelor's of Science in Health Science and his Doctorate of Physical Therapy from Lebanon Valley College in Annville, Pennsylvania. While he was here, he played Division III baseball for 4 years. John had an opportunity to complete clinical rotations across the country, including a rotation with the Cleveland Indians. If you're not familiar with them, they are a professional baseball organization in the MLB. While he was with the Indians, he was able to work with other medical professionals in designing and implementing rehab and injury prevention programs for professional baseball players. In addition, Jonathan has obtained valuable experiences in outpatient orthopedics and the acute care setting. John holds certifications in personalized blood flow restriction through Owens Recovery Science, suspension training through TRX, and has his emergency medical response for the athlete or ERA certification. In addition, he's a NSCA certified strength and conditioning specialist and a functional range conditioning master specialist. He is also currently pursuing his sports certified specialist certification for physical therapy, his dry needling certification, and his precision nutrition level 1 certification. John is really well versed in treating a variety of sports orthopedic and neurologic conditions, and that includes shoulders, elbows, knees, hips, ACLs, concussion rehab, you name it. This guy, if you couldn't tell by that impressive bio, is an absolute workhorse. He grinds 24/7. I swear he doesn't sleep sometimes. So, highly recommend you look into him. Give him a follow on Instagram. You can find him at diamond_doctor14. He's going to mention that once or twice in the episode if he can remember his Instagram handle. With that, too, make sure you subscribe to our podcast so you don't miss any of our upcoming episodes. We've got a whole awesome series coming at you real soon, including interviews with former NFL players, other physical therapists, chiropractors, athletes, strength coaches, you name it. So things that you're not going to want to miss are coming real soon. Before we get to the show, I'm going to have a quick word from our sponsor. John, welcome to the show. Excited to have you, man.
Thanks for having me, man. Appreciate it to be on.
So you're definitely not a stranger to the show, man. I mean, we've had you on a couple times early on. This is obviously our latest and greatest endeavor of John Harned podcast. So just kind of remind people who you are and what you do.
Name's John Harned. I went to Lebanon Valley College, played baseball there for 4 years. Graduated in 2018 with my Bachelor of Science in Health Sciences, and then graduated with my DBT in May of 2020. Did clinical rotations all over the country. Was in Arizona for 6 to 7 months. Had the great opportunity to work with the Cleveland Indians, which I was very thankful for. Learned a lot, and it's kind of helped me excel in the baseball world down here in the DMV area. DMV standing for Delaware, Maryland, Virginia, not Department of Motor Vehicles that I thought. I'm from New York, and that's what it is. That's the MVA down here. Graduated in May of 2020. I got accepted into the Johns Hopkins sports residency is the reason why I moved down here. However, because of COVID, my plans changed, program changed, things got derailed a little bit. So I took a little detour, and that detour had led me to True Sports Physical Therapy, where I started part-time just to, get some, money, experience before the program started. And then one thing led to another. I was offered a full-time position. After careful consideration, I decided to take it and politely turn down Hopkins. And now I'm the clinical director at our Woodbine location. And we continue to grow, opening several new locations over COVID and continue to look to expand. So things are great. Love where I'm.
And I mean, you're a year or two out of school and you're already a clinic director. I mean, how many people can say that, right?
I'll tell you what, I mean, I'm sure there are a few others out there that have, gotten there. It's overwhelming. It's hard. It's a lot of early mornings, late nights, but, it's what I love to do. And, I love working in this setting, this population. My coworkers are great. So kind of coming to work really doesn't seem like work. And I know that's cliche, but,
Right.
new things every day, fun every day. So I can't complain.
Right. What do you think sets true sports apart? Why is it that you're growing so extensively, especially in a time like now where it seems like so many clinics are struggling?
I mean, I think it's the culture that we breed. I mean, our goal and our mission and values are to provide the best care to any person we see. We are a very sports based company. My caseload is probably 90% athletes. But we see kids from all ages, older adults. I mean, I've treated kids as young as 7 to adults as old as 96. And that's no exaggeration. But we pride ourselves on giving the patient the absolute best care. We are one-on-one, so we have no techs, we have no aides, and that's, nothing against techs or aides. I've worked with great techs and aides. Um, but this new, or maybe not new model of therapy, but the model of physical therapy out there right now, where you come in to see your PT and they do their 15 minutes of manual therapy or hands-on stuff, and then you get past a tech or an aide and you're scheduling your 15 minutes. It's hard to keep quality of care there. I don't care how good you are, something's going to get slipped through the cracks. And I think that's why we have been able to expand. Success speaks for itself. People get better, one-on-one care, you can't beat it. You're constantly with a physical therapist, with their doctor who is cueing you, getting to know you, your life story, where you came from, where you want to go, your goals, and giving you what you need for your goals, not cookie cutter exercises or anything like that.
Right. And it seems like you're often coming up with new exercises and interventions for a specific athlete or a population that needs something. You're not just sticking to the bread and butter stuff, like, take a squat or a deadlift, for example. You're not just giving everyone squat, deadlift. It's, hey, let's do single leg RDL, but let's incorporate a band and let's incorporate some external forces to this area and this area during it. Or let's float our heel during that RDL. Let's do our squat on one leg instead of two. Like, there's endless customization options, I guess we'll say, for exercises that it seems like you're always coming up with. And it's taking these basic things and almost tailor fitting them to every patient.
Yeah. And that comes with time to learn, right? Like, you have your basic exercise library. I'll say I kind of make things up as I go based on what that athlete needs, right? You break down a movement that they need to do, whether it's a pole vaulter, a swimmer, a baseball pitcher, or your everyday weekend warrior. What what movements do they need to do pain free, and what movements do they need to do well? Break that down, and if muscle pull angles, muscle pulls and things like that, you can position somebody in any variety of positions and stimulate what you want. But it's also, ask that patient, you know, where do you feel this? What do you feel? Things like that. And you can actually find yourself making up or coming up with new variations or different positions to stimulate what you want, whether that to be more quad activation, more glute activation, different foot positioning to stimulate different things at the ankle, things like that.
Right. Now, you bring up muscle pull and angles, and you and I have talked pretty extensively in the past about anatomy. And I know that you've got this belief that programs in general teach anatomy wrong. They teach origin, insertion, and it does these actions at this joint. Plain and simple, cookie cutter. This is how it is, black and white. And I know that you felt that there's a problem with how programs are teaching anatomy. You've experienced that as a student, you've seen other students. How do you think we should be approaching anatomy instead of just, well, here's where the muscle attaches and here's what it does?
I mean, everybody's anatomy is essentially the same. You have a general origin, a general insertion. Um, you know, when it comes to exercises and doing stuff to stimulate that thing, that muscle, you can do it through a variety of your bread and butter exercise, or you can do it through a variety of, coming up with things and stuff like that. But I think the biggest thing when you talk about like that anatomy and the basics of it is, and when it comes to physical therapy, is start with like your things that are essential to, like, for example, like if you have somebody coming in with like standard knee pain, right? You figure out what it is, whether it's patellar tendonitis, patellofemoral pain syndrome. Know the difference between the two, and there is a big difference, and understand how those two things get irritated and stuff like that. But based on the anatomy, don't just treat it like a specific, like, oh, they have knee pain, so this is what we do for knee pain. But understand that in essence, everyone's anatomy is the same. But when we base it on those pull angles, just because one person feels, their quad a little bit more in this position doesn't mean that, someone else experiences it in the same position. So that's where that fine line of tweaking comes in during your session and your session, and you have to adjust for it. But essentially a quad is a quad and a hamstring is a hamstring. It's just making sure that based on different angles of pull and things like that, that they're still feeling that muscle engage rather than multiple muscles engage, unless that's your goal, if that makes sense.
Right. So kind of like that mind muscle connection, the neuromotor piece.
Yeah.
Along with that, one of the programs that I know has really transformed your approach to thinking has been functional range conditioning. And I mean, this is something you and I both know. We've both struggled with a ton of mobility restrictions in the past. I think we've been trying to fix my hips for years, and we finally got it handled. And I credit a lot of that to your knowledge that you've shared about functional range conditioning, things like pails and rails and cars. So with that, for people who don't know, what is functional range conditioning? What's it all about?
So functional range conditioning, or FRC, is just a system of training that looks at three main things for joints: functional mobility, articular resilience, and then articular health and longevity. It's just a basic concept, and you have different progressions within FRC, or functional range conditioning. The biggest thing that we think about is like, oh, somebody has no flexibility or someone's extremely mobile. And a lot of the times those terms are kind of used interchangeably, or, as synonyms or things like that. And they are very different. Like flexibility, if we think about it, is the ability to passively achieve a range of motion, right? Whether it's like a passive stretch, someone's doing it for you, you're doing a rope hamstring stretch, that's great, you're getting a stretch, but it's passively. It's essentially useless range of motion because you don't know how to actively get there. You're just taking a strap, or doing a different variation of a stretch, but you're not actually letting your body, your central nervous system, help you achieve that motion. Mobility is just the idea of moving and being free and easy, right? We're moving around, the ability to move physically. Functional mobility is the ability to achieve a range of motion actively, right? It's mobility for function. And that is the thing that we, as a society, trainers, whether that be, your CSCS guys or you're just your certified personal trainers or therapists, need to focus on. If we get somebody to increase their range of motion passively, that's great and dandy. Now you're just promoting increased risk for injury because they've never been in that range. They don't know how to operate that. So the idea of FRC is improving functional mobility and that ability to actively achieve that range of motion in a safe manner, but also being able to control that range of motion at end range. And then that's where all those little things that you kind of talked about come in. Your cars, your pails and rails, your things like that. And there's other ones to go off of that.
Right. So what do those mobility drills entail? So in general, what is a car? What is a pail? What is a rail?
Yeah. So CARs, they stand for controlled articular rotations. In essence, it's just a range of motion maintenance. It's your ability to determine your active range of motion, right? You do it at any joint, wrist, shoulder, and we can dive into the weeds of that, of exercises and video and things like that. But it's your range of motion maintenance. It's a use for health and longevity of that articular cartilage, because we know from physical therapy, schooling and stuff like that, that ligaments, tendons, articular cartilage, labrums, they don't really have a blood supply, right? So the only way for that tissue to get nutrients is by movement. pressure gradients, and diffusion and things like that. So if you're not moving, say, your shoulder, you can't really expect that articular cartilage and stuff like that to get nutrients. So that's why you move it, right? It's going to sound cheesy as all hell, but motion is lotion. Grease the groove a bit, right? We talk about, you and I with spinal mobility and stuff like that. If you're not moving that, hell yeah, it's going to get stiff, and hell yeah, you're going to lose movement and you're going to get back pain.
Yep.
You know what I mean? But it's also used for screening and stuff like that. So, where is this person limited in motion? Are they having excessive compensations? Like, for example, if you're doing a hip car, you're looking, you can do it in standing or whatever position you want. You're looking at how much range of motion does this person have in their hip. You're going to often find that they're going to start using their low back to get hip extension, or vice versa, or some other motion. But you can also, you're doing them every day, joint by joint, or however which way you want it, right? If you're having a shoulder problem, like I tore my labrum in the fall, or in the winter, excuse me, I was doing some cars. That tissue doesn't have, blood supply. Get some movement to it, get some nutrients to it. Your articular health and longevity, and then your screening and your rehab.
That makes sense. I like that complete articular rotation, complete articular range. And with that, like you said, you're taking your joint actively through its full range. So to me, that seems like something that would maintain range of motion perfectly. If you're someone who's like, hey, I don't need to increase anything, I just want to hold on to what I have, rip those in the morning and the evening, and I'm sure you're going to hold on to everything you got.
Them all day. And I mean, essentially what you're doing is you're engaging all those mechanoreceptors in that joint on a daily basis. And say you have an injury and stuff like that, you're delaying or preventing that onset of that osteoarthrosis, or that tightening, or that fibrotic buildup that comes with injury. Do you know what I mean?
Right. And that's the kind of thing that, joint replacement surgeries are becoming far too common anymore. I've seen them personally in people who are 50 years old. And, we have to ask ourselves as a society, is this the direction we want? Do we want people to be getting, a new knee replacement every 10, 15 years for half their life? Or do we want to take 5-10 minutes out of our day to do some of these functional range conditioning exercises and start working to prevent that? Personally, I see a lot of value in everything that you're dropping so far. So moving on to PALs and rails. Now, correct me if I'm wrong, PAL is progressive angular isometric loading, whereas rail is regressive angular isometric loading, correct?
Correct.
So with those, from what I've understood from them, because I'm lucky enough to have played around with them a little bit, thanks to people like you, it's kind of a stretching with an isometric load at either a progressive or regressive articular angle. And doing that expands your range of motion, but also increases your strength and increases tissue adaptation at that new range. So it's increasing your end range of motion, applying a neural drive to reinforce that movement pattern, and then strengthen the muscles in that position through isometric loading.
Yeah, you know what? My job's done. You just kind of hit it on the head. I'm going to go home now.
You did your work ahead of time because you taught me that.
Your PALs and rails are, your cars is your assessment. Where is this person limited? Your PALs and your rails, are your ability to achieve new motion, strengthening at new ranges of motion, and things like that. I like to think of your PALs and your rails almost as your middleman. At least that's how I kind of think about it, because there's 3 other things that we could talk about at the end. So to kind of break it down in a way that, people are, progressive angles, what does that mean? Regressive angles. So for example, you take your basic butterfly stretch, right? You're sitting, you're letting your legs go out, you're holding your ankles, your forearms are on your shins kind of. There's different buildups or levels. So there's like level 1, 2, 3, however you want to break it up. But in essence, what you're doing with these, and I'll like combine them in 2 and 1, is you're sitting there, you're going to go to that point where you have a stretch, right? Mm-hmm. Hang out there for like a minute or 2. The FRC course has approximately 2 minutes and stuff like that. So you can make sure everything is stimulated and stuff like that. You can play around with different angles or positioning of your body for essential stretches. But what you're doing is you would start with your rails, which is your regressive angular isometric loading. And what you're doing in your basic butterfly stretch, when you're going down, the muscle that is being stretched are your adductors, your things like that on the inner part of your thigh. Okay. Regressive meaning the angle is getting smaller. So you're holding that stretch for roughly 2 minutes. And now what you're going to do on a continuum, right? There's this law of radiation. When you do these, you should feel like you are working out. When I did the course and did pails and rails, I was sore the next day in my legs and my arms. I thought I worked out heavy. So you're going to think about contracting every part of your body when you do any pails and rails. A law of irradiation, right? You're not moving, but everything is tensed, right?
Mm-hmm.
So your legs are falling out. You're stretching your, adductors, your groins. Starting at roughly 10%, you're going to start irradiating everything in your body and almost giving yourself a subtle squeeze in with your legs, making that angle smaller, right? The idea of the butterfly stretch is to get those knees towards the ground. That's a progressive angle. We're getting larger.
Right.
You want regressive, right? So you're starting at that 10%, slowly irradiating everything in your body, then gradually ramping up 20%, 30%, yada, 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 all the point until you're at 100%. And 100% is hard as hell.
Yep.
You're squeezing, right? But you're not moving, right? You're squeezing into your arms. Your legs actually aren't coming together. And once you hold that 100% for a little bit, now this is where pails comes in, progressive, right? You are now going to activate those muscles that are going to allow you, your external rotators, your hip abductors, your things like that, to get those knees towards the ground or progressively increase that angle. And you're going to do that until you get to that point where you just can't go anymore. And you are going to literally try to break through that barrier or that wall. You might get some cramping. That's good. We call that neurologic confusion because your body is just like, what is going on right now? And then you hold that new range of motion.
And that kind of reinforces that new range. And I'm guessing you probably hold that for a prolonged period of time or as long as you can.
Yeah, essentially you're holding that new range for, 30 seconds, 40 seconds, a minute and stuff like that. And some people are kind of probably like, well, what is the difference between like P and F stretching? Isn't that kind of similar, like contracting and stuff like that? I'll tell you what, you are not contracting nearly as hard as you would with FRC or with P and F as you are with FRC.
Right.
This is creating so much neural drive and connection to your muscles and isometric loading that you will be sore and you will be building that like strength component. Obviously you have to load too as well in addition to this, but it is another tool in your toolbox for this.
I would imagine that this would help people in the gym too, especially if they struggle to get into those ranges or they know that there's a certain range where they're not strong at. Reinforce that range at the joint with that isometric load, right?
And you're killing two birds with one stone. You're working on functional mobility, which we talked about, being able to actively, so you're doing your CARS assessment, your warm up, whether it's a hip car or a shoulder car, whatever, a thoracic car, a lumbar car. And then you're going to rip some pails and rails, right? Isometric strength. If you have pain in an area, that's going to help that analgesic effect with those endogenous opioids. You're going to have some pain reduction. But you're also creating so much neural drive and CNS activation that you're going to be able to go rip whatever you're doing.
So as far as when you incorporate these in a therapy session, is this kind of start of the session, first thing you do, or is this end of the session, or just kind of, hey, as we need it?
I mean, it depends on what does that individual need. I've done it, in the beginning of my session. I've done it in the middle. I've done it at the end. It's all based on like your programming and what your desire is. I think it's great to start in the beginning. If that individual, is ready for that stuff, depending on what they're coming in for. But I just think is, you sprinkle it in as need be, and obviously in a manner that's appropriate where it fits into your session. Right.
Right.
End of a session is really good as well. It just depends. Are you, in what you're doing, are you going to use it as like a warm up mobility thing and then use whatever, exercises to help, to further reinforce what you just did? Or is there, are they just having a TLC day and you're just running through a whole FRC day? Not a lot of people probably know what TLC day is. Tender loving care day is what we call them here at True Sports. Your athletes who are just loading a lot. They need, they need a day of recovery. So.
Right. Now, speaking of recovery, there's certain exercise interventions that don't really leave a long-lasting delayed onset muscle soreness. And I know that they're great for athletes. For the most part, we're referring specifically to BFR, blood flow restriction training. I know you took the course through Owens Recovery, and that's something that you're really passionate about using. So for those that hear the word BFR and they think, what is that? What is BFR?
Well, BFR stands for blood flow restriction. Based on tourniquet principles, actually in the military. So including blood flow, not all blood flow, but for just a brief overview, what it is, and if people don't know too much about it, essentially it's trying to mimic the hypoxic environment of high intensity exercise, right?
Yep.
It's where you apply a cuff. And what I like to explain to patients, it's almost like getting your blood pressure taken, right?
Mm-hmm.
You can do one at, the proximal arm, so right in that armpit area, shoulder, or proximal thigh. And what you do is we pump it up to a certain limb occlusion pressure, LOP. And all limb occlusion pressure is the amount of pressure needed to cut off all blood flow coming back to the heart. So, arteries send blood away, veins bring it back.
Yep.
Owens Recovery Science likes to recommend pressures for the legs, and the arms. So usually for lower extremity exercise, we do about 80% LOP and 50% for the arms. BFR is so cool because the body needs like metabolic stress in order to build muscle and get stronger, right? So the master switch to muscle protein synthesis is that mTOR pathway. And BFR helps stimulate that. So in cases where people can't load a joint because one, maybe they just tore their ACL and they're 2 weeks out and obviously they're not doing anything, or 1 week out, or whatever, right? Or a shoulder, or they're coming in and they're just having some cranky knee pain because it helps with pain reduction. It is so good because what it does is it now allows you to load an individual at roughly 20 to 30% of a 1 rep max and get the same, if not better results than if you were to load them at 100% of a 1 rep max. And with that BFR comes changes in muscle activity, hormonal changes, increased protein synthesis. So, after you have that cuff on them and after you hit that lactate threshold, which is essentially that muscle burning effect that, people get, like if, you're a runner and you're like, oh, my quads are burning or things like that, that's that lactic, acid that, people say that they feel. You get a surge of, increased growth hormone. You get a surge of insulin like growth factor, and that's your muscle hypertrophy and your stuff like that. You get increased stem cells, that's your increased growth and repair. And it just allows us to load individuals in an essence where they need to get stronger, because obviously the stronger you are, the less likely you are to get hurt, without compromising a surgical protocol or putting that individual at increased risk if they are having pain and things like that.
Right. So the primary mechanism by the sounds is mostly physiological. You said increased growth hormone, mTOR activation, increased growth factors, and a little bit of neural kind of rewiring, so to speak. You said increasing that neural drive, increasing connection to the muscles, that sort of thing. So that sounds like the primary mechanism behind BFR.
Yeah. And it's awesome because if you think about it, if someone has surgery, you see muscle protein breakdown as early as 2 weeks. Studies range from anywhere from 20 to 40%, 30 to 40% is kind of that baseline. So if I can stimulate somebody's, mTOR pathway immediately and start getting them stronger in an area where, say they're on crutches and can't walk, after a meniscectomy or an ACL, I'll be damned if I'm not going to do it. I'm going to throw the cuff on them and, let them get to work. And it's also going to have that pain reducing effect. They're going to feel a hell of a lot better after the cuff or in the cuff than they did, coming into PT, and stuff like that.
Any interesting research that you like to look at on BFR? I know we've talked about the Alex Smith story a couple times.
I mean, there's so much new research out there, on stuff like that. I have a whole, Owens Recovery Science, BFR, we're within the course description. We can add that to the notes for people. In essence, it not only has, effect on, anabolic resistance, but also like it has been shown to help with aerobic resistance. So you can strap some leg cuffs on somebody and let them ride a bike. You'll get strength that way, but it also, work on the cardiovascular and, cardiorespiratory things as well. So I can add that into the show notes, but it's been out for a while. It's up and coming and stuff like that. And I use it almost every session.
Yeah. Yeah.
It obviously recommended, if needed, but I'm using it like 95% of my day. There's not a day I don't go and I don't use it.
Right. I think I remember a study looking at collegiate basketball players with BFR, and they increased their VO2 max by 11% in a month by doing BFR biking.
Yeah, I mean, think about it too. Like we work with a lot of athletes, and you're getting these athletes in different phases of seasons, whether out of season, in season, and stuff like that. So if I got somebody in season, you're obviously not like going super heavy to the point where that they're just not going to be able to perform at their next game. If I got a kid on a Thursday night, like today I had a kid plays a football game tomorrow, you got to know where they're at in their season. And that's the other crucial thing that it comes to when you're working with athletes and, and things like that. You can easily put BFR on them and have a maintenance and help build strength, when they need it, or if that's what they're here for, if they're recovering, and help flush things out and still feel really good and still get your work done that you need at 20 to 30% load.
Right. And the endurance benefits that come with it are often overlooked as well. I mean, how often do we just look at strength alone? It's great to be strong, but are you still that strong 70 minutes into your 90-minute match or in the fourth quarter when the game's on the line, when things really matter? So I like the protocols I see with the BFR too. I think Owens's, correct me if I'm wrong, was 15 reps each set originally for
So first set of 30.
And then 15, 15, 15.
And then 3 sets of 15. Because there's like a time effect too. I mean, sometimes I'll stray away from that, based on what load I give them and things like that. And obviously that is based on like clinical application and clinical judgment and stuff like that. But the basic essence is 30, 15, 15, 15. Another thing too I want to mention with the BFR is like thinking about it, even in your population, that, for example, could be bedridden or things like that. There's been studies that, they talk about cell swelling and, the pump effect. It's been shown with BFR that multiple inflation and deflation cycles, even without active exercise, can be effective for stimulating like muscle response and, and cell swelling response and things like that.
Right. And that should help with tissue healing as well, because people forget you need inflammation in order for tissues to heal.
Bring in more blood flow to an area. So your articular cartilage, like that we talked about with the FRC stuff, right? If they can't crazily move it, right? Like you have your ACL and, you're working on that extension and that, that end terminal knee extension strength, and you're doing what we like to call heel pops here at True Sports. Throw the cuff on them and they're also going to get some healing too in that area.
Right. Endless benefits. And this is easy to justify for anyone. So with that too, we've touched on FRC, we've touched on BFR.
I do want to say one more thing, because we hopped from the FRC stuff to the BFR after the pails and rails. There are a few things after the pails and rails, and I don't mean to like piggyback back and forth, but just for the audience out there so they know it just doesn't end at pails and rails. You also have things after like passive range holds, where you're, someone's passively bringing you to an end range of motion and then letting go and you have to hold that.
Yep.
There's passive range liftoffs, which is another thing. So say, for example, external rotation of the shoulder. Someone passively brings you there and now you have to lift off at that end range. There's hovers, which you're hovering at end range, and then end range rotational training, all of which being end range strength, functional mobility, stability, things like that. And that's why I said pails and rails are almost like that middle guy. So cars could be your assessment, your daily maintenance, your movement. Pails and rails are helping you increase that range of motion to get to end range. Now, all those passive range holds, those passive range liftoffs, hovers, and end range rotational training, that's your end range stuff, right? So you have your first third, your middle third, your last third, right?
Yep.
And
Makes
that's
sense.
what I just wanted to wrap the audience so that they knew those are out there too. And if anybody has questions and exercise things of how to do that and what it looks like, DM me, text me, throw my number. Everyone's got my damn phone number in the area. So what's a few more people, around the country. So
Right.
just for them out there so they have that.
Yeah, for sure. That's great information. And that's the kind of stuff too. It's easy to understand the progression. And obviously, functional range conditioning has the Con Ed course, which you took. I'm sure you would recommend that to pretty much anyone. There's also just some online content that FRC themselves put out. You can follow them on Instagram, YouTube.
On
I'm doing a
Instagram,
freaking plug for FRC right now.
tag them in it.
Yeah. So, and along with that, we've kind of been building up to this thing that is kind of your bread and butter, and that's knees. So we've talked about FRC, we've talked about BFR. Those are things that, you mentioned you can use those to treat things like an ACL. You mentioned using the BFR to treat ACL early on so you don't violate protocol, but continue to keep strength and function. So when it comes to ACLs, I think everyone, at least everyone from LVC's program, is familiar with the stat that 400,000 reconstructions are performed annually. And those numbers are slightly outdated. That number might be higher now. So when it comes to ACL tears, we've discussed this in the past in other episodes about how valgus collapse can kind of contribute to that, how estrogen can play a role, playing style limitations and mobility, stability, all these different things. But throwing that aside for a second, in your experience, what do you notice amongst athletes who tear their ACLs? What kind of common trends, common things have you seen?
I mean, just from a demographic standpoint, it's a lot of females. Your younger females, your teenage females, you will see boys, but mainly, especially, Maryland, not just in Maryland, but it's a lot of younger girls. Whether that be because of biomechanical differences, whether that be a slight delay in central nervous system signaling to a muscle, and there's that delayed motor response where it happens. But a majority of the athletes that we see are young women who tear their ACLs. Also, then you can dive in the rabbit hole of like sport and field, are they playing on turf or grass? Like a lot of things go into it.
So do you see it more often in turf athletes than field athletes?
I don't necessarily, would say that. I mean, Maryland's predominantly, there's a lot of lacrosse, so they're playing that on turf and grass. So I don't, I can't really speak for that, whether one more, whether it's more, turf or grass and vice versa. But, just from, studying, research, PT school, I know that is one factor that can contribute. I mean, I never liked playing on turf because my cleats got caught. Whether that's a rabbit hole to dive down to, I don't know,
So with that too, when we talk about rehab for an ACL tear, I mean, that's got to be one of the most rigorous rehab processes that anyone undergoes, right? Because it's long, it's slow, it's, progressive in the sense that you literally start over from zero. You start with that thing locked up and you just try and move it and regain range of motion. And then over time, over the course of 6 months to a year, you progressively increase to strengthening, to different exercises, and so on from there. So clearly an intensive rehab process. What sets you at True Sports apart from other facilities when it comes to ACL rehab?
I mean, the biggest thing that I would say is like what we talked about. It's like that the one-on-one care, like that's the stuff we do. But I've seen a lot of, or maybe not a lot, but like a good amount of athletes that come to True Sports in the past, that are, 4 months, 5 months, 6 months out from an ACL reconstruction, and their quad size and their leg size just isn't there. And people are like, oh, but it's strong. Well, if it was strong and solid, then it should be pretty damn close to the original size. So a lot of the stuff that I see is, when we, athletes that, come to us or stuff like that, is a lot of them are just underloaded. That leg, you shouldn't be trying to get that leg equal to the other side. You should be trying to shoot for that leg to be so much stronger.
Right, because otherwise you're running the risk of re-tear, right?
right? Like if that person isn't walking out, like obviously post-op, like those first 3 weeks are hard, but like down the road in that ACL, they should come feeling like they worked out,
Yeah.
right? And that's why it is so rigorous, because you're pushing them to the brink, whether it be if it's a quad day or if it's a posterior chain day, if it's, or if they're at the phase where they're running and cutting and stuff like that, a cutting day, whatever your splits are in your block. But a lot of the times when I see people that come in, they're just underloaded. Can't return to sport with that.
Right. And by underloaded, I'm just thinking back through my own clinical experiences. I'm sure you've seen something similar. Seems like anymore, people go to that cookie cutter stuff that we were talking about earlier. They go to straight leg raise. They go to sit to stand. One clinic I was in, the heaviest weight they had in the clinic was 15 pounds.
Yeah, that's not going to get it done for even if it's a general person,
Right.
you know, your weekend warrior or just somebody that is just, walking around, like they need to be loaded, right? No
Yeah.
matter who it is. And that's going to piggyback off of Dr. Mierzwicki's podcast. Like no matter what the age, they need to be loaded. But if you have an athlete and, the highest weight you have is 15 pounds, it's just not going to get it done.
Yeah. If you can safely load someone in the geriatric population, 70, 80, 90-year-old grandma, if you can safely load them with 80 to 100% of their 1 rep max, why are you not doing it for athletes? If you can throw a weighted vest at 10% of their body weight on them, which keep in mind, some of these people in that study, you're looking at 200-pound people. That's a 20-pound weighted vest. That's a lot more than they're used to. So
Right.
if you're doing that with grandma, why are you not doing that with the athlete? Or why are you not doing more than that with the athlete? Right? These are the young, fit, healthy individuals who everyone kind of looks at as, the symbols of strength. So why are we giving them the same stuff we give other people?
And think about their demands of sport.
Right.
Like whether they're a runner or a hockey player or a football player, they need to be strong. They need to be explosive. They need to change direction on a dime. They need to be quick. They need to have both they need to have eccentric strength, being able to control that knee as they're coming out of a sprint or changing direction, explosive power, isometric strength. Like there's a lot of different things that they need, and you need to give them that so that they can feel comfortable returning back to sport. I don't know the statistics now, but a lot of, if you dive into the research, a lot of people don't feel comfortable going back to sport or returning to the same level of sport.
Right. And with that too, look at the re-injury rate. I know we've had someone in the past on the podcast, one of the female athletes, who shared that she had 2 ACL tears back to back in opposite legs. So she tore one. She said, look, it kind of felt like grandma's PT. It was cookie cutter. They gave me a sheet of what to do and I did it on my own. And I was doing the same stuff as, the 70-year-old sitting right across from me. ACL rehab, the same as, a 70-year-old with osteoarthritis. And what happens? She gets discharged. She goes back on the court and literally a couple days later blows out the other ACL.
Yeah.
Just crazy how common this is becoming.
If you're an athlete, you need to understand what you should be getting out of your rehab. A lot of places out there advertise that, their sports medicine or sports physical therapy. Just be careful of what that entails and stuff like that.
Right. Because
I preach by the one-on-one. If you're an athlete or if you're whatever, you should be getting that one-on-one time. Unfortunately, not all business models are like that or therapy models, but everybody should be getting that. And if you're an ACL, you need that.
Yeah.
Not saying that other people don't need it. I don't want to be heard wrong, but like, just make sure you know what you should and need to be getting out of your therapy.
Look at the clinic.
The therapist also needs to know the demands of your sport. Like understand what you need to do. Breaks down a movement. Okay, you need to run or jump explosively. Let's work on this at the foot. Let's work on this at the knee. In your respective phase of rehab, in order to get you to do that. If they don't understand what the demands of your sport, then how can they accurately assess and create a plan of care for you, and whatever injury that is, whether it's ACL or whatever, in order to get you back to doing what you love to do better. That's what we're striving for. We're trying to get you back. We're trying to get you back being better.
Right.
And that's how we separate ourselves from other companies out there.
And I think I'd ask the question too, did your physical therapist play a sport? Like, do they understand what your life entails as an athlete? Do they understand, like, up late on a road game away, waking up the next day to go to an 8 a.m. class? Like, do they understand what that life is like? And that goes for many different populations. You yourself played collegiate baseball. Other individuals like myself, I did skiing, wakeboarding. Like, I've done a lot of sports. It's just not your typical what you might consider a team sport. And these are all things that people do, right? We have ski racers, we have professional wakeboarders, water skiers, all these different things. So your ability to look at what they're doing and say, like, just reiterating your point, this is what they need right now because this is what they're going to be doing there, is I just echoing your point. It's such a missing piece. And it just kind of leaves you to wonder, like, why is it that people are missing this? Why is it that people don't understand how to analyze movement, especially when they're considered a movement expert?
I mean, I think it just goes back to not falling into that trap of prescribing exercises to just prescribe exercising, understanding what a specific individual needs, breaking down a movement, understanding a rehab process for whatever, if it's a post-op, like understanding how to treat an ACL,
Right.
understanding how to treat a hip scope or, a labral tear conservatively and both post-op. I think a lot of things go into it, but the biggest thing, and what, was taught here and what I teach my staff PTs is understand why you're doing what you're doing and not just doing.
Yeah. Well, when there's a purpose for every action has a result. It's simple. So
Right.
if you can defend what you're doing, it might not be the best reasoning, but if you have a defense for it, it's probably going to have a result. And like, there's been times where I myself personally have given someone something and been asked, why are you doing that? And I'm like, look, it's going to work on this. And someone will say, well, this would be a better option to do that. And I'm like, yes, it would. I agree, but they're not there right now. So I can't just throw this at them and say, go do it if they can't even do this basic movement. So kind of putting an example to that, say we have someone with patellar tendonitis, right? So if they have tendonitis in that kind of quad region, knee region, and we're following kind of old school standards here of eccentric loading, then everyone would go with the Spanish squat, I would think, 9 times out of 10 as the gold standard exercise. But if someone doesn't have the ability to do a correct body weight squat, am I going to put them in a Spanish squat setup with the bands and tell them to crank away on that for, 3-4 sets of 10 reps with 10-second eccentric? Probably not. I'm probably going to want to get things correct first. And, whatever we got to do to get that, whether that's utilizing a TRX or just working on cueing to get a proper movement first. And then when you go to rehab, not only are you correcting the issue, so in this case, tendonitis, you're also correcting it with a proper movement pattern. So it's just adding to that neural reinforcement like you added before.
Yeah, I mean, in essence, whatever it is, whatever, that you're treating and stuff like that, whether tendonitis or, whatever, you're going to progressively like build them up in a manner that tissue, like, and you also have to understand like tissue healing times or whatever it is, or things like that with whatever you're talking about, when they're seeing you in that phase of rehab. Obviously, you're not going to have them perform a movement and it doesn't look good and it could be contributing to their symptoms and stuff like that. So obviously you're going to clean it up and do whatever correctives you need to, like for that patellar tendonitis or before that, with that acute stage, whatever injury it is. Obviously the biggest thing first is like, and I don't even know if this is answering your question, but like going from a standpoint of rehab, like you want to calm that tissue down and then progressively build them back up in like a pain-free range, or like I won't shoot for anything more than like a 3 or 4 out of 10, because they're probably gonna have some level of discomfort, but like obviously you don't want it more than that. And then use the description of pain as your guide. Is it sharp? I don't like sharp. Is it dull and achy? Okay, we can work with that. They're probably, if it's acute, gonna have some form of discomfort. And like with your tendonitis thing, like your patellar tendon stuff, like you can't just not load that area because it's just going to make things worse. But
Right.
you also can't do it to the point where it's like debilitating.
Right. It's a
Right. So like,
balancing
that's
act.
where like heavy isometrics come into play, and stuff like that. And, your patellar tendon lunges and things like that. So you can rebuild that tissue up. And it's also understanding like, where do you mainly, like, since you brought up patellar tendonitis, like where do you mainly see that issue? And it's usually like your jumpers, like your explosive athletes. Like you're probably not going to see like a patellar tendonitis thing in like somebody who's just like walking.
No, we hope not. Anyways, it's called runner's knee or jumper's knee for a reason.
Right. So I'm going to be honest, I don't even know what the question was. We were just talking, but it's like, you
Yeah,
need to understand where that, individual is in with that respect to their injury and like the healing time for the tissue, and understanding when and when not to progress, when to regress, and with that tissue healing time, like where they are, and like understanding how isometrics come into play, and things like that.
it's all about those phases of rehab, and your patient can literally change phases in one session. They can go from phase 4 to 2 and back to 3 or something.
I mean, every day is an evaluation day. I like to think about it. Every day I'm doing an eval, right?
Right.
Every day I see that patient, it's a new day. How are they presenting? What are they coming in with? Maybe they're a little better than last time. Maybe they're a little worse. Maybe they tweak something. Every day is an evaluation day, and you need to treat it as such, because you need to, and you don't want to get that person better. They're seeking you out, and as you have the knowledge and can give them that knowledge to help them. But treat every day like an evaluation day and go from there.
With that, John, any kind of closing thoughts or anything you wanted to add about FRC, BFR, PT in general, or ACLs, knees, that sort of thing?
I mean, if anyone has questions about the BFR or, the FRC stuff, you have my email. It's jharned@truesportspt.com. You can add that into the notes. I have 2 Instagrams. What was it? I don't even know my handle.
I think it was Diamond_Doctor14.
Something like that. We can add that. And then there's a J Harned one. That's like my personal one. I don't even know. We can add those in at the end. I don't know the.
Yeah, I'll throw them in there.
People can message me or, text me. I love to chat.
And athletes can schedule with you guys too, obviously, right? Just reach out to you.
Just DM me. I'm here for you. Night, early morning, late at night, a Sunday, Christmas Eve, whatever you need, I'll be here.
That should be your new slogan: Christmas Eve, whatever you need.
Hey, I like it.
It's got a good jingle to it there.
We're laid back, and that's the biggest thing with the since we're a big athletic population is, and for people that want to work with sports, you live and die by the athlete schedule, right? It's based on when they can get here. So, a lot of times I'll have midday gaps because just no one can get here. The school thing, kids are away, or I'm coming in super late, maybe a 12:15 start, but I'm staying till 8:30, 9:15 at night. It's a long day, but, it's no similar than a 9 to 5, but, it's fun, and stuff like that. Advice for PT, whether it's you want to work with sports, you want to work with, pediatrics and things like that. And it's something that I learned here, and it's a quote, that my boss is telling me, and it kind of spoke to me when I was, interviewing here. It's people don't care how much you know until they know how much you care. And that speaks wonders for how we at True Sports do things and stuff like that. You don't need to be the smartest PT in the world or the smartest guy, right? Just it's just caring for that individual, right? Everybody is human. We're all human in the most basic form, and giving them what they need to achieve any goals that they have in life. And if you do that in PT or just in your general life, the amount of satisfaction and inspiration that comes out of that is tremendous and will supply you for a lifetime. So
definitely, for sure. That's great advice, man. John, as always, pleasure talking with you. Pleasure having you back on the podcast. This has been a long time coming here.
Thanks for having me. I think the last one when I was actually studying for my boards.
Yeah, it was a while ago. It was like a little
Arizona or
motivation
something.
Monday thing. I forget what we were ranting about, but we were on our high horses that day. I remember.
Probably had a little bit too much coffee and not enough sleep.
Yeah, either that or the gym session that morning was a little too spicy. We probably had Papa Roach going or something like that. I don't know.
We're not spicy enough.
No, never. Always a pleasure, man.
Always a pleasure. Thanks for having me, Dan.